Hello and welcome to the Social and Behavior Change in Family Planning and Reproductive Health course. My name is Olivia Carlson and I'm thrilled to be here today with two of my colleagues from Breakthrough Action to walk you through the materials. My other two colleagues who you will meet in a moment are Utra Bharath Kumar, who's a senior SBC capacity strengthening advisor for Breakthrough Action at the Johns Hopkins Center for Communication Programs, as well as Zoe Hendrickson, who's an assistant scientist at the Hopkins School of Public Health, as well as a research and evaluation officer at the Center for Communication Programs. And as I mentioned, I'm Olivia Carlson. I'm a program officer working on Breakthrough Action as well at the Center for Communication Programs. By way of background, the Breakthrough Action Project is an 8-year cooperative agreement funded by USAID to lead social and behavior change programming around the world. It's a partnership led by the Hopkins Center for Communication Programs, but we have several partners, including Save the Children, Think Place, Ideas 42, Camber Collective, ICRW, and Viamo. The main goal of the project is to ignite collective action and encourage people to adopt healthier behaviors. So we work in a number of different health areas, and I will show you on the next slide in a moment what some of those are. And we do this by forging and testing and scaling up new and hybrid approaches to social and behavior change. And these approaches are informed by several different fields, including social and behavior change communication, as well as marketing science, behavioral economics, and human-centered design. And then on the right side here, we just have a few examples of some recent resources the project has produced. If you're interested in perusing all of the resources, or these ones in particular, you can visit our website at www.breakthroughactionandresearch.org, and you can find everything we've produced there. As I mentioned, we work across a number of health areas. You can see that on the left-hand side here. Today, we're going to be focusing on family planning and reproductive health, but I did just want to share with you that Breakthrough Action is working across a number of different areas. So if you're interested in any of those areas, I would encourage you to check out our website as well. And also just wanted to highlight that the project brings together experts in several different areas, including audience segmentation, advocacy, behavioral analysis and economics, community engagement, digital, gender, HCD, marketing science, and of course, social and behavior change communication. So there are a lot of folks working across different fields, bringing their expertise to the project. And on the right-hand side, you can see some examples of campaigns the project has implemented. And again, if you're interested in learning more about any of these campaigns, you can find that on our website. So now moving into the agenda for today, this is the end of the introduction and agenda portion of the session. And in a moment here, I'm going to pass it off to my colleague Utra to take you through the Social and Behavior Change 101 overview. And then that will be followed by 3 different sections organized around the social and behavior change flowchart, which you will become very familiar with by the end of today's session. As you can see here, there are 3 phases. The first is define, the second is design and test, and the third is apply. So we've organized our content around those 3 areas and hope it makes things a little bit more digestible today. And with that, I'm going to pass it off to Utra.
Hello, and welcome to the first segment, Social Behavior Change 101, an Introduction. You may already be SBC practitioners. You may have a lot of experience with family planning. There's no doubt. Thank you for joining us, because today we're here to persuade you, not to persuade you, but really to stir the glass, to present a few ideas for your consideration. Imagine a scenario where you are in country X, where the vision for individuals and or couples to meet their desired reproductive intentions is there. However, the unmet need for family planning in country X among adolescents is about 28%, fairly high. And this is now your fictional country X, but there are countries where this may be as high. Can you brainstorm and think, why might unmet need among adolescents in country X be so high? Pause this video for a second and write down some of your thoughts on why you think this is. There are actually a great many reasons or factors that can influence behavior. You have individual level behaviors, factors, you have social and gender norms, you also have structural and policy issues that may be a challenge. So what are some of the factors at an individual level? There could be attitudes and beliefs. What kind of beliefs and attitudes exist among young people that might support or prevent practice of the behavior or health outcome? And not just among adolescents, it could be among the people around them, right? But these are influential to the young person. Expectations. What do people feel will happen as a result of practicing a behavior? Knowledge. Do young people know why the behavior is important and how to practice it? Self-efficacy. Do young people feel confident that they can practice the behavior? Do people have the right skills or the training to carry out the behavior? Do they feel a threat? How concerned are people about the outcome the behavior will prevent? At a social and gender norm level, you have gender norms that are defined as roles and decision-making factors between men and women that could inhibit the practice of a certain behavior. So in this case, adolescents can be influenced by gender norms in the community, in their families, in society, with their religion, and so on. Social norms. And what do people think others in their community or social network do? Do they practice the behavior? Do those people actually practice the behavior? Are there informal rules that govern this behavior in the group or society? These are some things to take into account. From a structural and policy level, access and availability can be an issue. Are any of these products or services required, the ones that are required for practicing this behavior, available? Meaning, are contraceptives available? How difficult is it for the target population to access them? In some cases, youth can't access family planning methods. Affordability. What are the financial barriers or supports to practicing the behavior? Policy. Are there supporting protocols, policies, or laws that promote or inhibit or mandate the behavior? In some countries, it's illegal for young people to obtain family planning methods below a certain age without parental consent, or unless they're married. Then there's quality of care issues as well. Does the provider of a required service for this behavior follow quality standards, protocols, guidelines? Are they empathetic? Do they treat the young people with respect? So there are a great many factors that influence individual behavior. So these factors resulting in unmet need can be individual, they can be social norms or gender norms, or structural policy related. The good news is that SBC can help address most of these factors in some way or another, even if it's advocacy for better structure or policy. SBC is a part of the solution, not all of it, but an important part of the solution, because there are other issues as well beyond SBC that need to be in place for young people to meet their family planning needs. So I'd like to present 4 key ideas on SBC for better reproductive health outcomes. There are many ideas, but we've chosen 4 in this context to share with you. The first idea is that there's no ideal public health outcome without social and behavior change. If you can consider national family planning objectives, within those are the social and behavior change objectives. SBC objectives contribute to the overall national family planning objectives. They amplify the effects of service delivery and policy to increase family planning uptake, right? So service delivery, contraceptive availability, all of this is very, very important as well, and as part of the national family planning objectives. However, the SBC objectives are important to take into account because they contribute to the overall family planning objectives. For example, if this is a real story, one of my colleagues was invited to the World Health Organization to make a case for social and behavior change in fighting TB. And he was asked to bring as much data as he possibly could to support his argument for why social and behavior change is really important in fighting TB. However, he went there with empty-handed and said to them, I didn't bring any evidence. And there was a lot of murmuring and dismay, and people were like, how is this possible? He came with no evidence. And he said, okay, give me a second. What are some of the key challenges in fighting TB in your countries? And people came up with things like drug availability, affordability, trained service providers. But they also came up with issues like compliance, stigma, knowledge about what is and isn't TB, the symptoms, treatment seeking, taking their drugs completely, social support for TB, and so on. And he said, well, more than half of the issues that you have cited are related to behavior, are related to social norms. How do you imagine you could address these without an SBC intervention? Right? So what you'd need is not really evidence. And if you need evidence, there's plenty out there. The question is not to keep asking for evidence, but to see how critical SBC is as a part of the larger context in fighting a disease or adopting family planning or any of the health issues you're talking about. So it can amplify service delivery and not instead of it. The second idea I'd like to present is that investing in SBC is cost effective. The business case modeling in Zambia done by Breakthrough Action's sister project, Breakthrough Research, found that every dollar invested in scaling SBC saves between $2.40 and $5.30 when accounting for direct health costs and productivity losses. And this is the days that are lost due to people not working due to pregnancy or maternal deaths or disability, and so on. So if you take that into account, avoiding unplanned pregnancy can actually save money, right? This is a case study for Zambia. There are other countries in which the similar kind of case study has been done, and without an exception, you can see that investing money in social and behavior change saves more money in the long run. So SBC can be cost effective, and we will share links to all of these resources towards the end. Where does SBC usually fit into a country's family planning program, in your experience? Think about it for a second. Where does it usually fit in? Typically, it would be at the very end, right? After you finish designing the program, let's add in some IEC. Let's tack on some posters, right? When the program is largely clinical or service delivery focused, at the very end you would add in a few posters, maybe a radio program, something. And usually if there's a funding crunch or a budget cut, usually the communication, the IEC or the SBC gets cut first because it is not really seen as essential. And sometimes funding isn't even available to fund it fully, right? Not strategically. So the third idea I'd like to present to you is to suggest let SBC be the steering wheel and not the spare wheel, right? Let it be the steering wheel. Let it lead the program. Let's lead with behavior rather than adding it on towards the end, tacking it on towards the end. And when you think of SBC interventions, what comes to mind? What do you immediately think of? Pause the video here and take a second to jot down what comes immediately to mind. It's likely you thought about things like posters, leaflets, and so on. How often does SBC get reduced to this? A program claims that SBC was done when in effect a poster or a leaflet or a community sensitization talk, usually a one-way lecture from an expert to a group of people, happens. And they're like, SBC is done, check. Often, even those are not strategically developed in terms of the content and the audience and the information that's needed. Does it address a barrier? And it's almost never evaluated for its effectiveness. Did the message reach? Was it effective? Did we convey what we tried to convey? So quality SBC that is strategically developed is evidence informed and theory informed, right? It requires good quality formative research to understand what the barriers and facilitators are for the behavior. And then it addresses those facilitators and barriers, individual as well as social and gender norms, to the practice of target behaviors with the ultimate goal of creating sustained behavior change, not temporary behavior change, right? And it's context specific, it's audience centered, it's developed through meaningful partnerships with communities and addressing their perceived needs. It can and should be monitored regularly and evaluated consistently. It requires close collaboration and coordination with policy and with service delivery programs and mechanisms. Because to be effective, you need SBC, but you also need all of the pieces to come together to achieve your family planning objectives. So SBC is a science and it's an art, right? We can't be boring when we're trying to reach people. So how is SBC science and an art? Science, because we have to do the research, right? And we have to strategically plan. We have to think about the barriers, the enablers, and so on. And it's an art because we really do need to reach people. This is idea number 4. It's not just enough to invest in SBC, but need to do it well and measure it to know whether it worked, right? This is an example from Zambia where young people needed to be reached, adolescents needed to be reached with family planning content, reproductive health content, and all of the research showed that they didn't have dedicated time and dedicated approaches that would reach them with the information they needed. So a multi-pronged creative approach that addressed their needs was created. Not only was a adolescent wellness day developed, which is here, where a day dedicated to young people to come and have their own time. And it was called Wellness to make sure that they could get information not just about reproductive health, but about malaria, about personal well-being, about keeping themselves healthy, about self-care, about future goals, and so on. And so they were excited to come and access these services, right? Because they felt special. One of the other challenges that our research showed us that they felt that it was not a confidential counseling session. When they met with the healthcare provider, they felt that their information was not confidential. So a training was created for healthcare providers called NIZI, which means shh, keep it to yourself. And once the providers went through the training, they would receive a badge that says NIZI, and also they'd sign a pledge that says, I commit to keeping everything my clients tell me completely confidential. And on the table would be a tent stating a confidentiality pledge to remind the young people that they will keep this information confidential. And this increased the trust that the young people had in the healthcare providers and allowed them to come and access the services. And in addition to that, information about reproductive health got out through road shows, comic books, post little comic strips on social media platforms. So it wasn't a question of boring lectures, but reaching young people where they would be interested and how they would be interested, right? So the 4 ideas to sum up: there is no ideal public health outcome without SBC. Investing in SBC is cost effective. SBC should be the steering wheel and not the spare wheel. And it's not just enough to invest in SBC, but we need to do it well and measure it to know whether it worked. I'd like to share a small video with you that illustrates this concept. So join me in watching this.
Social and behavior change, or SBC, is an essential component in achieving countries' family planning commitments and global development goals. SBC interventions use a deep understanding of human and societal behavior to increase adoption of healthy behaviors and influence the social norms that underpin those behaviors. There are 3 key reasons why SBC is an essential component of any family planning program. First, SBC is rooted in global evidence and best practices and shown to increase successful outcomes in family planning. Second, SBC approaches complement service delivery investments. And third, SBC demonstrates a high return on investment in both the short and long term. Let's take a closer look at each one of these. First, global evidence shows that SBC improves family planning outcomes. SBC interventions have been proven to positively impact intermediate outcomes, such as approval of family planning and open communication with a partner, and have a direct effect on modern contraceptive use. For example, the Nigerian Urban Reproductive Health Initiative was able to increase modern contraceptive use in one city by 15% by using multiple SBC approaches, including TV, radio, and community engagement. Second, SBC complements service delivery investments. SBC interventions improve health outcomes and enhance efforts along the service delivery continuum before, during, and after a person goes to a health facility. In Rwanda, the Banda Pahero project created a supportive environment before women went to family planning services by holding counseling sessions in the community with women and their male partners. The project resulted in multiple positive health and gender-related outcomes, including an increase in modern contraceptive use, increased support from men for reproductive choices, and improved decision-making power for women. In Indonesia, mass media and community education were used to improve clients' participation in family planning counseling sessions. As a result, more clients prepared questions for their family planning provider prior to their appointments and improved their communication with the providers. Third, SBC demonstrates a high return on investment. Peer-reviewed research has shown that SBC interventions are cost-effective and provide a high return on investment. Data from Zambia and Guinea has shown that every dollar invested in high-quality SBC to improve family planning uptake saves between $2 and $6. Achieving family planning goals is within our reach. When we invest in high-quality SBC interventions, we can amplify our family planning work.
So by the end of this session, these series of sessions, we hope that you will appreciate that SBC is an important part of achieving good family planning outcomes. That you'll be exposed to something we call the SBC flowchart, be familiar with terms like behavioral economics and human-centered design and the role that they can play in SBC. Understand the fundamentals of monitoring and evaluating SBC programs. Have a cheat sheet to be able to critically look at the SBC programming and ask the right questions to ensure quality. And also access a list of curated SBC resources to go through later and share with SBC practitioners in country, including things like the video that you just saw, tools and other great ideas that you can share.